Okay, then let's start. I think people are joining, but I will introduce you first, I think. So, hello, everybody. Welcome to the second monthly meeting of the Enigma Sleep Talk series. As I said previously, it's open for everybody to join. And if you have any question, you can ask at the end of the presentation or put it in the chat, and then we'll discuss at the end of the talk. As I always say, it's a great pleasure to introduce our speaker today, Professor Kai Spiegelhalder, who is doing a very intriguing research on insomnia disorder and neuroimaging. And today he will talk about the same topic. Kai obtained his PhD in psychology, and he's also a medical doctor from University of Freiburg. He got his degrees in 2008, and he got an extraordinary professorship at the Albert Ludwigs University of Freiburg in 2018. And he's also a co-chair of the ENIGMA-Sleep working group as well. Thank you, Kai, for joining us today and accepting my invitation. It's a really great pleasure for me to have you here, and the stage is yours. Yeah.
Thank you very much. The pleasure is on my side. Hello, everybody. I hope you can hear me well. I would like to speak about, well, neuroimaging studies in insomnia. And I have at the beginning a quick outline for you of my talk. I would like to start with a very brief introduction of what is insomnia. So what am I studying here? And then I have two sections. The one is that it's a bit from my very subjective perspective on this field. The first section is on a rather long area in which very small studies have been conducted. And recently, or yeah, at least I became a bit tired of that and had the impression that it doesn't lead us anywhere. So I made some attempts to conduct some more epidemiological brain imaging studies on insomnia, and I would like to present these to you afterwards. So I start with the question, what is insomnia? Insomnia is probably familiar to everyone. Most people have once in their lifetime problems either to fall asleep or to maintain sleep. So you wake up in the middle of the night and have problems to fall asleep again. This does not meet the definition of insomnia if you just have this for a week or so. In most diagnostic systems, insomnia is defined as having a problem with initiating or maintaining sleep. And this in the DSM has to be at least for a duration of 3 months, then you would call it an insomnia. There are two other criteria that need to be fulfilled for meeting the criteria of the disorder. Criterion B here is sounds a bit funny. It's called the sleep difficulty occurs despite adequate opportunity and circumstances for sleep. Usually people understand that this means you do not have a child that is maybe less than 1 year old, or you are not in a acutely life-threatening situation, like maybe in a war or something. And last, the nighttime symptoms have to be associated with some form of daytime impairment, at least on the subjective side. So I think most frequently patients report problems in the cognitive area or mood disturbances. Yeah. So this is insomnia, quite broad definition, I would say. And this is what I spend my life with, studying it. And a lot of my work is dealing with neuroimaging studies. When it's about the question, is insomnia important or not, I always try to present this slide. I also work a bit clinically. There are definitely, and I work in a psychiatric clinic, there are definitely psychiatric disorders which lead to a higher burden of disease from the perspective of the individual patient. If you think about schizophrenia, for example, or severe forms of depression. However, the overall impact of insomnia is not as small as some people might think if they see it from a clinical perspective, because just very lots of people are affected by it. So the prevalence is around 5 to 10%, maybe in industrialized countries. Some studies even suggest, even when they're not conducted by insomnia researchers, that it might be the most prevalent psychological disorder or psychiatric disorder that we have. Although one can, of course, debate whether this is a psychological disorder or a brain disorder or a somatic disease, maybe. It's a bit in between the fields, I would say. People suffer from it. I think that's very clear. So they have a reduced quality of life. But also there is epidemiological work suggesting that it may be even causally related to depression, to the development of depression and cardiovascular disease. I won't go into detail about this here, but this is not just the typical, we have a longitudinal epidemiological study, but it's based on Mendelian randomization. So there are some hints that it might even causally be related to these two most prevalent diseases in industrialized countries. So this is somehow a summary for why it might be important to study insomnia. One quick slide about the treatment. Insomnia is most often treated not as it is recommended in clinical guidelines. Actually, all clinical guidelines that I know that have been published in the last 5 years around the world recommend that a very specific psychotherapeutic treatment should be used to treat patients with insomnia. However, the reality is quite different to that. This treatment is rather simple, I would say. It's not what you would usually expect from a psychotherapeutic treatment. It's quite easy to learn and to explain. It's not the focus of this talk, of course, but it's from my perspective, I'm doing this now for almost 20 years. It's still a bit surprising although it's quite successful treatment in studies, that it has problems to be implemented in the real world. And I would like to illustrate that with this slide. This is data from Germany. If you think about this pie, and the whole pie are all patients with insomnia in Germany, then if you look at the health insurance data, you would estimate that approximately 75%, this is the black area here, never receive a diagnosis. That's probably not a surprise, because that's probably true for most psychiatric disorders, might be even worse for obsessive compulsive disorder, for example. But from the section of those who receive a diagnosis, only 1 in 10 persons, that's the green area, receive a psychotherapeutic treatment. And this means any psychotherapeutic treatment for any disorder. So this might also be people who also have an anxiety disorder and receive a psychoanalytical treatment for anxiety disorder, for example. The red area should be much larger. This is because it's based on health insurance data. Most of the benzodiazepines and benzodiazepine receptor agonists are today prescribed on so-called private receipts, or how it's called in English, I don't know, sorry. People have to pay for that by themselves. So many people more take these substances than you can actually see in the health insurance data. So that was the introduction. That's insomnia, what I spent my life with somehow. And now I would like to speak about some studies with small sample sizes, as I called it, although I'm not really speaking about the studies. I'm more trying to give you an impression of the trend here. When I started to do insomnia research, it seemed to me that there is some kind of a typical study in insomnia, and I did a lot of these studies. And the typical study in the field of insomnia is you take 2 groups. I mean, that's what you probably would expect what people do. And then you have roughly 20 people per group. And one group, of course, has insomnia, the other group, healthy sleepers. These should be illustrated by the figures here. And then you measure something, like, for example, cardiovascular parameters, or that's on the left side, the figure, or polysomnography, and the second one, or brain imaging data, or on the in the subjective area, some questionnaires, for example. And then you have not only the typical study in insomnia, you also have kind of a typical result if you try to summarize all the literature in these fields. And I have here 3 quotes for you from some of these reviews of the literature. And this is always quite similar, no matter what you look at. It's always goes in the direction of there's inconsistent evidence to suggest that heart rate variability, one parameter, is impaired in insomnia. Studies investigated neurobehavioral performance have produced inconsistent and somewhat conflicting findings. And we don't really know that much about the pathophysiology of insomnia from these small-scale studies. And this is also true for the brain imaging field, I would say, although Masoud is currently revising this paper. I still show it because the new one is not out yet. The same was true 5 years ago, actually, for the neuroimaging field. It seems when you try to look at is there any convergence between brain imaging findings in terms of the localization of significant findings or significant differences between insomnia patients on controls, then it does not seem that there are consistent brain alterations in insomnia disorder. So I've also published a review on this 3 years before, and there we were quite optimistic and said, well, this might be altered, trying to summarize all these small-scale studies. However, I have to say, this figure didn't age very well, because today I would probably not subscribe any of these, I would probably am not of the opinion that any of these findings are definitely true findings. And my impression is, or my suspicion has always been that a field that is entirely based on exploratory data analysis in very small samples and people having a high pressure to publish significant findings and ignore non-significant findings has a very high likelihood of producing such an inconsistent pattern of findings. And this is actually what happened, and what somehow my explanation is for this. There are other explanations. Like, for example, I think some people believe more that insomnia is such a heterogeneous disorder that we probably, in all our small-scale studies, we probably all have very different samples from each other. And that's why one group finds more something there and one group finds something more there. And probably both are somehow true, in my opinion. So, but as my take from this field was, well, I'm not sure how much sense it makes to perform these small-scale studies. I also came a bit to the conclusion that my belief is that I'm not able to conduct a study with meaningful results in the time and with the money I have, because I'm not sure whether it makes sense to perform studies with at least these studies comparing two groups with each other with less than 200 people per group or so. So I wondered, well, maybe there's data out there from epidemiological studies that we can analyze with respect to insomnia. And that's where I became interested, or the point at which I became interested in the UK Biobank. And probably many of you know the UK Biobank. It's an epidemiological data set that is basically, if you want to write an application for doing that, is free to use and to analyze from the UK. There are roughly 500,000 participants, aged between 40 and 69. They are overall considerably more healthy than the general population, which is a disadvantage of or a limitation of the UK Biobank, I think, and probably a bit better educated. But still, it's a very rich data set, and the goal was always to have 100,000 people investigated with brain imaging techniques. And so far, we have data from 40,000, I think. And in the UK Biobank, we also have data on sleep. And only one question about insomnia. And this question is something like, do you have problems initiating sleep or maintaining sleep? And there are 3 answers that you can click on. It's a multiple choice question. Usually never or rarely. And we usually compare them when we analyze this, the usually group against the rest. The usually group are something like 25% of the population of the UK Biobank. So this is the closest we can get to prevalence rates of insomnia. So we did a couple of studies with the UK Biobank. I have to say in the beginning, this is rather easy to do. It has not that much to do anymore with any knowledge that you need from the neuroimaging field. I always had lots of fun to do neuroimaging studies because I really like the math behind it, and it's a quite complex thing actually. And I also thought I had some expertise in this, but this is not necessary at all if you analyze UK Biobank data, because the Oxford Imaging Group has already pre-processed all the data to a stage in which you actually basically have your final dependent variable that you analyze, and you don't have to do anything with it anymore. So for example, we looked first at morphometry. This is not published yet, but it's about to be published soon, I hope. And there's a study led by Masoud and Antoine Weiss, which also combined different data sets, which came to the similar conclusion. That's why I also cited it below there. It's the second citation there. And this is maybe a bit unusual presentation of the results of an imaging study. This is usually the way genetic results are presented. I think it's a Manhattan plot. On the x-axis, you see different brain areas. These are free surfer-based brain areas in all the people in the UK Biobank. These are, I think, 139 areas. And on the y-axis, you see the p-values, basically, of the comparison between those with insomnia symptoms and those without insomnia symptoms. And the final sample was here 33,000 people. And as you can see there, it's the negative logarithms of the p-value. So if the higher the value is in this graph, so the higher in the graph, the lower is the p-value. So a value that is significant after Bonferroni correction would have been above the top line that you see there, the horizontal line, because that's the line for p-values for Bonferroni correction. So basically nothing is going on, right? Everything is below that. And also if you look at the raw differences between the volumes of the different areas between insomnia, those with insomnia and those without, you see that most are in the range of -1% to +1%. And that's the difference between the two groups. So one group, for example, has for the hippocampus 3,000, and then the other one has 3,015 or something. So less than 1% more or less compared to the other group. So this was a bit the disappointing area. There was another disappointing area, I would say, and that was a functional neuroimaging task that was also included in the UK Biobank. This was published last year. It's the so-called Hariri task. And during this task, you see pictures presented to you by people who express different emotions. And you have a matching task. You have to click on the right or left side and indicating which of the two lower figures matches the upper figure. So in the example of the three gentlemen over there, it would be the left side because that's the same figure as the upper figure. The control condition is the same just for shapes. That's what you can see below for these oval shapes. The figure on the right side is maybe a bit hard to grasp. This is actually the comparison, again, between the two groups. On the right side, those with insomnia symptoms. On the left side, those without insomnia symptoms. In purple, you see the individuals, which is a bit difficult to see because it's 30,000 people. But what you can see from the box plots is that this looks very similar and actually is very similar. There was no significant difference between the two groups. I would like to mention one further thing at this point. We have also analyzed, or the same group of people has also analyzed whether there is a relationship of the activity. Sorry, I forgot something. The main outcome is the activity of the amygdala in reaction to the emotional figures in comparison to the shapes. I should have said that. That's why you can also read there on the y-axis amygdala reactivity. And so that's also why the average is positive, because people react more with the amygdala to emotional stimuli than to shapes. So you see that most of the values are above 0 here in the figure. What I would like to emphasize is that some people in the insomnia field always, when they don't find something, they always blame insomnia for the problem and always say, well, it's insomnia. Probably it's not an important disorder. We also didn't find anything for depression, and this is also published. So there doesn't seem to be any relationship between depressive symptoms and amygdala reactivity to emotional stimuli, which is probably a surprise to those working in the depression field, I guess. You can also see one thing here. I usually claim that since the data is pre-processed by the Oxford Imaging Group, that we can really trust this data. However, they made a slight mistake, and one reviewer told us this. Not sure whether you can see that, but there are surprisingly many people who have exactly 0 as a value in this figure, because the line with the 0 is a bit darker than the upper and lower parts of that. This is somehow a mistake that we came across, and we told the Oxford Imaging Group that there is a mistake in there. These are people in which the amygdala was not detected at all. And so since there were no voxels within the amygdala, the signal was 0 in the end, and they should have been excluded from the database. Since we have pre-registered our analysis, we didn't exclude them here for the primary analysis, but we also did the sensitivity analysis after excluding them, and nothing changed. So this is, again, a bit disappointing. Then the third publication might be the one that sounds most interesting somehow, if from the standpoint of trying to find something that is related to insomnia. This is about functional connectivity. Here I am. I would like to select 2 of these results. We somehow found a tendency that there is an increased connectivity within the default mode networks, or at least within 2 ICA components. Actually, ICA was used in this functional connectivity analysis. And then you had different components, and some of them were related to the default mode network. And between 2 of these, there was an increased connectivity. In red and blue, you can see again kind of a box plot for, or whisker plot for insomniacs and controls. Red are the insomniacs. So you see again, the difference seems to be very minor. However, one might argue that epidemiological studies usually underestimate effect sizes because their measurements are not perfect as we do it in small scale studies. And if you have lots of error in there, the effect size gets smaller. But still, if the effect is there, so it might be actually in reality a bit larger than you can see here. And we also had some effect in the frontoparietal network, also an increased connectivity within that. However, I today spoke again with the first author of this paper an hour about this. Our impression was still that this is not the breakthrough we were hoping for. The findings seemed a bit too random from my point of view. They're correctly corrected for multiple comparisons. I'm completely fine with that, but still, it doesn't seem like we really found something that we would have expected, that makes a lot of sense anatomically and so on. Also, there were some findings in areas which we would never have expected, some connections between cerebellum and visual cortex, for example. And so it still doesn't feel like we are really close to finding the pathophysiology of insomnia, right? I think it's worthwhile to wait for the next 20,000 and reanalyze that, and maybe it's still there, maybe it isn't. However, it doesn't feel like we're very close, and now we can do treatment studies or whatever to try whether we can alter these findings. And so I actually found it a very good opportunity, this talk, to somehow reflect on this whole field. And to be honest with you, I really had lots of hopes in these epidemiological studies, imaging studies. And I'm not too sure why it's still very difficult to find something that is related to insomnia in my case. And one might think, who or what is to blame for this, right? And I come up with 4 solutions here. The first one is insomnia might be to blame for this, right? If you're an insomnia researcher like I am, you will always be in situations in which you give talks to other people, and you're often welcome as a speaker because it's a good thing to speak about. Let's point it like that. But most people somehow question whether it's a really important disorder or disease, right? So sometimes people maybe think something like, do we really, as a state, Germany, need to pay this guy to do this insomnia research in Freiburg? Aren't there more important things to do, for example, right? And since everyone who's doing insomnia research always encounters these questions or these doubts, we are probably also all a bit self-skeptical, and well, it might be. On the other hand, we did most of the analysis also for depression, and we also didn't find anything major for depression. And there we have exactly. I'm not a depression researcher, but my superficial impression is that it's very similar, the situation in the small scale studies. Everything inconsistent, everyone reports a different area. And then the large study report very minor alterations, if there are any, right? So I'm not sure whether insomnia should be blamed. Actually, also, I believe even if insomnia is very heterogeneous, I would have expected that there's some kind of something that have people in common who have insomnia in the brain, right? Let's say the end of the neuronal network or neuronal path that actually leads to this subjective experience of insomnia. For example, if you compare it, if you look at the effect size of the subjective experience between insomnia patients and controls, you have an effect size of 3 to 5. So very large effects. The subjective experience is extremely different from people who sleep well. However, the effect size of the imaging research is probably, if it's credible, is probably more in the 0.1 area or so. Okay, so this is one solution. It's insomnia. Second solution, it's the biobank. Actually, Masoud, you also brought up this point before. Maybe the measurements are just not good, right? This is always the case if you present epidemiological data. There are always people who say, well, insomnia is not really well assessed, right? It's just one question. You have only 3 answering options. Is that really state of the art to assess insomnia? And that's a good point, of course. However, I'm also not fully convinced that this is the best argument to go with. And the reason is that you actually can do the math. If you calculate, or let's say, if you guess what the sensitivity and the specificity of your question is for your condition, insomnia disorder, and even if you guess a ridiculously low number, like 60, 50% or something like that, for sensitivity and specificity of this question for insomnia disorder, then still your power is so much higher in the UK Biobank with a large sample size compared to the small scale studies, even if they have a sensitivity and specificity of 100%, what you would expect basically in the small studies. I have a slide on that, but it's very complicated. And if any one of you is ever interested in that, just write me an email or do the math by yourself with a simple power analysis, actually. So that's also an argument which I can partially share, but I'm also a bit skeptical about this. And I think the genetics researchers have a bit understood that. And if you go to genetics consortia, they usually don't care about being very precise in phenotyping. They just care about sample size because they think, well, it all goes to the arrow, but in the end, we need large sample sizes. And then no matter what the error is, if there is a small signal, we will probably find it. And 2 more solutions. I also thought for a long time that I might be the problem here because to be honest, I was like that before. In my small scale studies, you will also not find many results. And I always had the impression, well, maybe I didn't do this well. For example, I'm not good in tightening the hat of people in the scanner. I'm always too nice to them, right? And it really produces a large error in the data. So I was always a bit fearful that this might actually explain why I don't find things that other people find. Or I always also thought I actually believe that I'm not that bad in statistical analysis, but imaging analysis are very complex in my view. And they are prone to errors. If not two or more people do the same analysis and you find exactly the same, you can make errors. And there are lots of chances to make errors. And I was always wondering, oh, maybe I did an error here and there, and that's the problem why I never found something. However, as I said in the beginning with the UK Biobank data, this is completely free of my influence. I've never put this tightening around the hat of these people. And the analysis is so straightforward because you just receive the dependent variable in the end. You do nothing for the pre-processing and so on. And I think it's a quite credible group who's doing this. And so I'm really wondering why there's still nothing going on after the factor me was eliminated somehow. And the fourth explanation is my favorite one, but that's just my subjective opinion. Maybe the brain is just too complicated to with our current methods. It's just very difficult to find something that is really solid. And I'm a bit struggling with that, to be honest. And I'm happy to discuss that with you. I'm really wondering how to move on after having analyzed this data. Of course, I have some ideas, and I also do. I still do small scale studies, always with within subject repeated measurements. So I always do treatment studies now to increase the power, and I think this may make sense. However, with the biobank data, I'm not really sure how to move on from here. Well, of course, we can wait for more data. Maybe there are more biobanks, then we pool them, and in the end, we are like genetics researchers and have millions of people, and then we find the signals maybe. However, it's more a matter of waiting than of really doing something, in my view. Because as an insomnia researcher, I'm not conducting the biobanks, of course. That's it. I was very quick. I'm a bit sorry for that. Actually, I have an hour, but maybe we can discuss more also. I'm already done. I thank you very much for your attention.
Thank you so much. As always, very, very interesting talk.